Hello, and welcome to Primary Tooth Pulp Therapy, a 3M SB webinar. My name is Greg Saltis, and I am a pediatric dentist in Olympia, Washington, in the United States. I want to welcome each of you to the program. To some of you, I say good afternoon. To some of you, I say good evening. To some of you, I say thank you for getting up in the middle of the night. According to my count, we have people attending from 30 different countries, including 6 continents. So we have people here from everywhere, and I thank you for your attendance. I'm always happy to talk to people who are interested in providing excellent care for children. And certainly being able to provide primary tooth pulp therapy is a critical piece in providing adequate care for children. My goals for this program will be to help you understand how to diagnose properly, how to determine which teeth are candidates for pulpotomies and pulpectomies, which teeth should be extracted, and how to do the procedures. During the course of this program, I will talk about different medicaments that are currently being used and the advantages and the disadvantages of each. My goal is for each of you 1 hour from now to have a much better understanding of how to treat primary pulp in order that you can also treat your patients in a more complete fashion. So without further ado, I would like to begin right away to get right into primary pulp therapy. The first question that must be determined, of course, is a diagnostic question. Are we talking pulpotomy, pulpectomy, or in fact, are we talking an extraction? So I would like to begin by talking about the radiographic pulpal diagnosis by showing some x-rays that will help you to understand how to best determine what is the proper course of care for the child in your chair. If we begin with this simple diagram and you look at it on the screen, you will see on the left side of the screen, you'll see that over here we have a very small lesion, which, and even in a primary tooth, I would continue to call an area of watch, not treatment. On the right side of the screen, you will see an area here that I would certainly call a class 2 restoration, be it MO or DO. However, now as you look at the screen, you're going to see a different picture. As we look at the screen now, and I am looking at the left side of the screen where you see the circle, when you have a lesion that is at least 1/3 of the way into the tooth, you really should be thinking in terms of a stainless steel crown. This is an important point because many times I see very large restorations that fail. However, when you put a stainless steel crown in a situation like this, you will have a much greater likelihood of success. However, on the right side of the screen, inside of the circle, you will now see a totally different situation. This is a lesion which, as it is diagrammed, is approaching the pulp of that primary tooth, and in all likelihood will ultimately end up in some form of pulp therapy. As a rule, radiographs, the caries on radiographs will be smaller than they actually are in the child's mouth. The reason is obvious. You have a 2-dimensional picture of a 3-dimensional object, and as such, you cannot know exactly how far into the tooth that lesion has gone. As a result, it becomes important for you to look at the depth of the decay, and the other factor that becomes critical is to know the age of the child. And by age, I mean the dental age, not the chronologic age. So as we start moving ahead toward the area of looking at teeth, let's look at this pair of bite wing radiographs as a pediatric dentist might look at them. The first thing that I noticed on this radiograph is the fact that we have 2 unerupted 6-year molars in the lower dental arch, and of course 2 that you cannot even see in the maxilla. As a result, it doesn't really matter to me whether this child is 4 years of age, 9 years of age. It doesn't really matter, because what I know is that we do not have erupted 6-year molars, which in dental terms means that you probably have a child who is about 5. This becomes important in your treatment planning simply because you must know how much longer the tooth that is being considered for treatment will still be present before being exfoliated. The 2 very large lesions that you see on the 2 lower first primary molar teeth then are on teeth that this child will likely have for a minimum of 5 to 5.5 more years. The second piece of information I gleaned from this radiograph is the fact that this is a child who has come in for a 6-month periodic examination and has already had other treatment completed. Now we're seeing more lesions. As you look carefully at the radiographs, you will see interproximal caries such as right here on the mesial of that upper left second primary molar, the mesial of the lower left second primary molar, and probably on the lower right hand first primary molar as well, possibly on the upper right first primary molar. However, I want to draw your attention to the large lesion here, and of course the two that the arrows are pointing at, which become very significant lesions in terms of treatment planning. There is no question in my mind but that I am going to plan a pulpotomy on that tooth right there, as well as this tooth right here, simply because of the fact that we have already seen the child receive treatment, and in the case of that lower left-hand tooth, which is on the right side of your screen, we are seeing a failed DO restoration already. Certainly we're not going to go in and put another big restoration. We're going to crown both of these teeth, and we are also going to plan on putting pulpotomies in each of these teeth to make sure that they will be secure. As we move along, I want to start pointing out more areas of pulpotomy indications. This is a classic picture that you can see where that upper first right primary molar has a lesion which is very similar to the diagram that I showed you a moment ago, where you have the caries that are approaching the pulp, which you can see very clearly in this radiograph. And clearly this is a child who is likely to have a pulpotomy done on this tooth. We'll talk in a moment about how it is that you determine whether a child will need a pulpotomy or a pulpectomy, which is the pediatric term for baby tooth root canal. But for the time being, I want you to become accustomed to looking at radiographs and determining how big the lesion is and also what the dental age of the child is. Now in this situation, we can see the 6-year molars that are clearly evident and in place, so that we can be confident that what we have here is a child with a dental age of a minimum of 6 years. However, as you look at the lower right-hand area of your screen, you will see right down in this area here that you have a first primary molar tooth that still has its roots entirely intact. And what that tells you, anytime you have a primary tooth with roots that are totally intact, you will have that tooth present for a minimum of 2 more years, a minimum of 2 more years. When you are in that situation, you know that this is going to be a child who will need to have the care of the pulpotomy on that upper tooth and consider it in the lower tooth. So once again, it becomes vitally important to be considering the age of the child as well as the size of the lesion. One of the things that you can see slightly on this x-ray is you can see how that upper second primary molar has begun to drift into the space of the first primary molar due to this large carious lesion. The next x-ray will even show it in greater detail. All of us who treat children on a routine basis have seen this picture before, where you have the 2 large back-to-back or side-by-side interproximal lesions on primary molars. It is very common for first primary molars to have large distal lesions, partially because of the flat anatomy of those first primary molars and partially because of the thinness of the enamel on that tooth. So to see a picture that looks like the photograph on the left side is very common. It is also not unusual to see a second primary molar, which you see at the bottom of the picture, with that large mesial lesion, so that now what we have is we have tremendous space loss in this area. I would say to you that if you saw this tooth prior to the carious activity, probably it would look something like this. The distal would be about here. And if you saw the second primary molar prior to the carious lesion, it probably looks something like this. So by demonstrating that, I want you to understand that what I'm saying is that we'll often have space loss, so that interestingly, restorative pediatric dentistry will often be considered a space maintainer. So when you have a situation of this sort, if we now look at the radiographs, we can see the very large lesions that occur right between those 2 teeth in the circle, and we can see how close they have come to the pulp chambers. These will definitely be pulpotomy candidates. As we continue on here, I want you to look at this x-ray and just take a moment to look at it first before I begin to talk about it. Now that you are a little bit more accustomed to looking at radiographs from a pediatric standpoint, you should now be able to glean considerable information from this about the longevity of the teeth, about the age of the child, about the depth of the decay, and about the appropriate treatment here. However, unlike the other x-rays, this x-ray has features to it that will be significantly different than the ones that we have seen before. When we are looking for indications for pulpotomies, and you have probably already seen them on the radiographs, to my eye there is no question that both of the upper second primary molars indicated by the arrows are going to be in need of a pulpotomy. Given the overall condition of this child's mouth, I would say that the lower right-hand second primary molar, which is on the left side of your screen and has a large occlusal lesion, would certainly be a candidate for a pulpotomy. You can see from the radiograph that the upper 6-year molars have not yet erupted into place. As a matter of fact, I would estimate that they are not clinically apparent and still subgingival. The lower 6-year molars are in place, so I would put the dental age of this child at about somewhere between the ages of 6 and 6.5. But let's take another look at the x-ray now, because some of you are probably thinking, well, gee, he didn't really say anything about these two teeth down here. What about those two lower second primary molars? Aren't they pulpotomy indications? Well, let's take just a little closer look at those. If we are now considering what a pulpectomy is about, a pulpectomy is when you have a tooth that actually has carious contact with the pulp chamber, and you are going to see that in the area right down in here, inside of that circle that you are now looking at, you can see that there is a likely communication of the carious lesion with the pulp chamber, and as a result you are probably also going to notice on here that there appears to be a slight change in the interradicular bone appearance as you are seeing it on the screen, as opposed to the other side where you see that nice thick bony area. So when you are beginning to see changes of this sort, you must consider the possibility that this tooth may end up being non-vital and in fact will end up needing a pulpectomy. That is the tooth right there. However, now let's take a look at this tooth here, that lower first primary molar tooth, and what you're seeing here is a totally different picture. You are seeing the carious lesion coming in from the distal and communicating with the pulp chamber. You are seeing the mesial root that is beginning to resorb away, and you are seeing that completely radio-opaque, radiolucent area in the interradicular area. So you see a progression of total bone health here, as opposed to possible changes here, to complete loss of bone here. This is a tooth, because it is a second primary molar, which becomes a much better candidate for a pulpectomy or baby tooth root canal than a first primary molar. This is a tooth that you really want to try to save, even when you have some bony changes in this area. First primary molars, however, are very difficult to clean for the pulpectomy procedure. So in my practice, when I see a situation of this sort, I will remove this tooth and I will put in a band and loop space maintainer, because the chances of success of a pulpectomy on a first primary molar is substantially lower than it is on a second primary molar. That has to do with the actual anatomy of the pulp chambers themselves. Second primary molars tend to be very much like miniature 6-year molars and have very regular, very strong, and very definite pulp chambers. First primary molars, on the other hand, tend to have very thin roots, very, very small and fragile canals that are easy to perforate when you are considering doing a root canal on them. As a result, my recommendation would be, when you see a situation like you were looking at the screen, the first primary molar, because of all the circumstances we've talked about, would probably be an extraction, as opposed to the second primary molar, which even in the face of some bone changes is still a candidate for the pulpectomy procedure. Let's take a look at some more of those sorts of situations. So here is a classic example of a periapical radiograph of a child, and once again I invite you to take a moment to really look at this radiograph carefully, to glean information from it yourself. What I'm hoping you are seeing is you were seeing solid bone that is over the 6-year molar. We can see this right here, solid bone. So that probably this is a child who is in the age group of possibly 4 to 4.5 years of age. Now what does that mean? That means that this second primary molar is going to be in the child's mouth until the age of 12. We have 8 more years of use from this tooth. First primary molar, which usually will be lost at approximately the age of 10 to 10.5, will at least have 6 more years. However, let's take a little closer look at what we see going on here based on the conversation I just had a moment ago. First of all, if we start taking a look at the first primary molar tooth, the things that I want you to notice here are the interradicular bone, which is basically completely gone now. I also want you to notice how thin those canals are and what I would call possibly some change in the interradicular canal shape, possibly some internal resorption here due to the infection where the decay has gotten straight into the nerve chamber. This radiograph is especially strong at showing the ingress of the decay into the chamber and how it can actually change the internal structure by actually having a decaying process going on within the root of the tooth. In a case like this, this tooth is absolutely going to be an extraction, no question about it. Now, let's take a look over here at the other tooth. Now, when we're looking at the second primary molar, we're seeing a similar situation, but with some significant differences. First of all, let's acknowledge that we have some change in the interradicular bone. I'm sure we can all see it here. I'm sure we can all see it down here. We can also see what appears to be the point of ingress into the nerve chamber right in this area through the occlusal and potentially over here. However, as I am looking at this radiograph, I am seeing a regular pulp chamber coming down this side of the mesial side as well as the distal side. I'm also seeing a third root over here. So, as we look at this tooth, we're seeing a difference between the second primary molar and the first primary molar, but there is another reason why you would want to pursue treatment on that second primary molar. The reason is because one of the main functions that these second primary molars perform is the guidance of the 6-year molar into the proper location. If this tooth were to be lost prematurely, you would find that the 6-year molar, which again, this x-ray is particularly strong at demonstrating this, would continue its mesial inclination and come right up into this area, and you would have a substantial space loss because of the fact that this tooth was not treated. As a result of that, pediatric dentists will be very vigorous in treating second primary molar teeth, even with pulpectomies, even with some loss of bone here and here, because it becomes so important to maintain that tooth in order to get the 6-year molar in place that a pediatric dentist will do almost anything to retain that tooth. The first primary molar is a totally different situation. When one loses a first primary molar prematurely over here, if that tooth is lost, it is easy to put a band on this tooth and a loop up to the cuspid and have a band and loop space maintainer to hold that space. If you lose a second primary molar, however, you will have to put something back here, presuming you still have the tooth. Namely, you would put a crown here and a distal shoe space maintainer in order to engage that tooth for the 6-year molar to erupt into its proper position. Any of you who have done a distal shoe know that that is not a simple procedure. Let's take a quick look at some other teeth that I would call unrestorable, and then we are going to move right into the procedures themselves. So, first of all, as we are looking at the teeth here, we are looking at a second primary molar, which I just told you we would do almost anything to restore, and yet if you look at that tooth that is now in the picture, a couple features that I want to point out. Number one, the lesion has come all the way down subosseous. The other thing is you can see changes in the chambers in here and in here. You're seeing some internal resorption here, which means that it is not a strong candidate for doing a pulpectomy. The most difficult thing about this tooth is you're going to have a very hard time getting a crown to stay on that tooth. The other thing that's critical here is the fact that the 6-year molar has already erupted. So you couldn't put a band on this tooth and make a lingual arch that comes all the way over to this 6-year molar over here. Let's take a look at a couple of other teeth that are unrestorable. I think we can all agree that that tooth that we're looking at there is probably pretty close to coming out. We can see the bicuspid above it that looks like it is not that far away from coming in, so that we would have the opportunity to take that tooth out and possibly see the permanent tooth come in more quickly. Now the other tooth that I want to point out to you, is the one in this larger circle here, and it is likewise, much like the tooth over here, we're seeing that it is decayed all the way down to the bone. It would be very difficult to be able to put a crown on that tooth. For that reason, the 3 teeth that are in the large circles I would call unrestorable and would be extractions. Once we have this tooth out, and this tooth out, the appropriate thing would be to put a band on that upper second primary molar and a space maintainer, put a band on the 2 6-year molars, and put in a lingual arch. Let's take one more look at some unrestorable teeth. I'm sure I need not point them out to you here. When we're looking in at the upper anterior radiograph, we're seeing a tooth that is virtually resorbed away. We're also seeing the appearance of the permanent incisors that are dropping down with some root loss here. None of these teeth would be strong candidates for pulpotomies or pulpectomies, although I would argue the point that perhaps this lateral incisor could be saved, but then one must consider how important is it to save a single tooth. As we look at the lower teeth, I'm sure all of us would agree that this lower right first primary molar is absolutely unrestorable, and that this one would probably be heroic to get a crown to stay on that tooth, although in my practice I would try. But as we're looking at the large lesions in these 2 second primary molars, now you know that with an unerupted 6-year molar, if we run into the pulp here, we are going to want to do everything to save the teeth. Because I'm not seeing any change in the interradicular bone area, I think this is probably the developmental sac of the permanent bicuspid forming. These 2 are likely pulpotomy candidates, not pulpectomy candidates. Let us now move on to the oral examination so we know which teeth we're looking at and when we should be suspicious. However, for the most part, I do my diagnostic work based on the radiographs. This is a picture, sad to say, that we see very commonly in my practice. As a pediatric practitioner, I notice that we still have all primary dentition here, so we have a young child. There will be 4 crowns done on these teeth because no restoration, either amalgam or composite, will be able to really restore these teeth. In the case of the second primary molars, for another 6 or 8 years, first primary molars 4 to 6, like a stainless steel crown can. Probably, I would say to you that it's likely that both of the right side molars, left side of your screen, right side of the patient, will be pulpotomies. I don't see any swelling in the gum area. Left side molars, I would be very suspicious and suspect the same. This is actually the same child that you just saw in the upper. You'll notice one little cusp tip here, so we know the child is probably approximately 6 years of age. But as we look at this very large OL and the mesial lesion here, on the other side, very large OL with the mesial lesion here, I would have to say to you that the likelihood of either or both of these being pulpotomies and stainless steel crowns is very high. Briefly, we have a situation here where we have unrestorable teeth. Once again, it's just tragic to see children that come in who have teeth that are in this condition, such as the one with the circle. You can already see that we have some soft tissue bubbling up within the crown form of that tooth, which means that that one is not possible to restore. And to be perfectly honest with you, I don't even recall exactly what we were looking at on the child's left-hand side, but I'm sure that you will agree that we have a former root here and some mild part of the tooth, a little bit of the tooth remaining here. And this is on a child with no 6-year molars in place. This is truly a dental tragedy because this child will not have an easy course with bilateral distal shoes. This is a case where we see a child with some history where we can see immediately there's been a tooth lost here, possibly because a large restoration was attempted. So as we're looking at this tooth, there's no question in my mind but that we are going to be doing a pulpotomy and a crown. I simply want to introduce you to this tooth because it will show you how clinical appearances can be deceiving. This was a radiographic diagnosis, but I just want you to take a quick peek at this upper right first primary molar tooth, and we're going to come back to it, and I'm going to tell you what I had to do for this tooth. But just look at the clinical appearance. It looks like a basic, well, probably a large occlusal, but certainly nothing involving the pulp. And last of all, we have one more tragic situation here where once again we can see that we have a tooth that really is unrestorable. I'm sure that you will agree that that tooth that is in the circle, you can see the soft tissue bubbling up through the pulp, what used to be the pulpal area. That is an unrestorable situation. The only good news I can tell you about this x-ray is we have a 6-year molar that's appearing here. I don't see it on the child's left side yet, but as soon as those 6-year molars come in, we will be putting bands on them and putting a lingual arch in. In the meantime, the chances of space loss is fairly high. When you have a child come in with a clinical appearance such as you were looking at here, where clearly you can see that we have significant swelling of lingual tissue and buccal tissue. You can see the draining purulus. You can see the food that's been packed into this distal lesion. If you could touch this child's tooth, I am certain it would be quite mobile, and the radiograph would show that we already have so many changes in the internal aspect that this is not going to be restorable. So sometimes the diagnosis will be clinical, and many times the diagnosis will be radiographic. So now, let us move on to the actual procedures themselves. We're going to begin with the pulpotomy procedure. We're going to begin with formicrosol. Formicrosol, at this point, speaking in the United States, it is still the most commonly used medicament, and it is the most forgiving technique, which means that it is not quite as demanding in terms of the technique that you must use to have success. However, it has had controversy regarding carcinogenicity. The other thing is that if you have used formicrosol, you know that it has a very strong smell in the operatory, and often will not be well received by the parents when they smell it and they begin asking questions. If you happen to live in a place where you have parents who have been on the internet, as we all know and love, they will say to you, gee, what is that material that you're using? And when you tell them, some of them will actually say, well, isn't there some concern about formalin being a carcinogen? So I simply want to give you the heads up that this is one of the situations that you must be aware of with formicrosol. Having said that, let's go straight into an explanation of how one goes about doing a successful formicrosol pulpotomy. The first step will be to open up into the chamber with a high-speed burr. Normally, when I open up into the chamber, it's only because I have already had a carious exposure. Previously in my training, I was told that if there was a lesion that even approached the nerve chamber, you should simply dive straight in with intention. Nowadays, with the advent of glass ionomers for indirect pulp caps, if you do not have a direct exposure, I now wait until I actually see hemorrhaging coming from the tooth. And if I do, then I will open up with a high-speed handpiece to go into the pulp chamber. The next piece will be to amputate the coronal tissues by using a slow-speed burr running at the fastest speed that your slow-speed burr can run. In other words, you want to get that slow speed going very fast so that it's not cutting any of the hard tissues, but it goes fast enough to cleanly amputate all of the tissue from the coronal aspect of that primary tooth. You want to make sure that you have removed all of the coronal tissues and eliminate bleeding. If, after you have completed this step, you are still seeing hemorrhaging coming, probably it is because you have not completely taken all of the tissue out. Now you're looking on the screen at probably a number 8 round burr, which is my typical burr for treating second primary molars. As I have said many times, what will happen is that when a second primary molar is opened up, you have nice large chambers to work with, and they require a number 8 round burr so that you can only go to the top of the radicular portion of the pulp chamber, as is diagrammed on the left side of your screen. You can see the burr in place, and in that same picture, you can see the depth to which you want to be amputating the coronal tissue, right to here. When you are done, you should have a picture that looks just like this. We often laugh and call it snake eyes because you have 2 little red dots looking up at you, but you will notice that there is not a lot of hemorrhaging happening at this point. That is indicative of, number 1, a good candidate for a pulpotomy, and number 2, adequate coronal removal of all of the tissue. If you have continuous bleeding, you probably have one of 2 things going on, either tissue tags, so you would repeat the procedure of going back down in with your number 8 round burr and then putting cotton in there to dry it and seeing if that is adequate and get this appearance. If you have done this 2 or 3 times and you find you're still getting bleeding, you probably have a hyperemic pulp, and then you have a pulpectomy candidate. Then you know if you can't stop the bleeding by simple coronal tissue removal and cotton application, this is not a good candidate for a pulpotomy. Again, the classic picture that you want to show is 2 small stumps that have no bleeding, but you can still see exactly how they look with the red tissues in there. Once you have completed that, the next step is to place a couple of well-dried formicreosol pellets into the chamber, and you leave them there for about 3 minutes. The way that formicreosol works is different than the other agents that we'll be talking about. The way that formicreosol works is it actually works on the actual vital nerve tissue, and it will fix those tissues. It actually mummifies those tissues. So in a moment we'll talk about another medicament that works in a totally different way, but it's important at the moment to understand that the mechanism of action of formicreosol is to mummify the vital tissues, and after you have left the these cotton pellets in the chamber for about 2 to 3 minutes, you will then remove them, and the picture that you should be looking at will be 2 pulp stumps now where you see little black spots in there. It's a little harder to see in this picture, but they look pretty much like this, because whereas you had the red stumps before, you should now have black stumps, because what you have done is you have now fixed the pulp stumps so that they are no longer vital, and you are now ready to place your packing. Once again, at this point, if you are seeing hemorrhaging, it is probably because you have tissue tags or because of the fact that it's a hyperemic tooth that requires a pulpectomy. With formicreosol, you have a little bit more leeway in that it will penetrate into the most coronal portion of the radicular portion of the nerve, so that you can actually get the stump fixed and place your medicament next. When you are prepared with a well-fixed stump, with a pair of well-fixed stumps in the chamber, you now mix a thick zinc oxide and eugenol cement. It should be thick enough that you can actually condense it. So you don't want to make it too runny. You want it to be doughy enough that when you place it in there, you can use a plastic instrument or an amalgam condenser or something so that you can actually condense it and completely fill the coronal chamber. There was a recent article published in the American Academy of Pediatric Dentistry journal that talked about using fillings with and without eugenol, and the findings were that when eugenol is used, it will be a substantially higher likelihood of success. So I continue to believe that filling the chamber with a ZOE is the way to go. Once you have done that, you can fill it right to the brim. You can see the hatched lines on the left side of your screen with a well-filled chamber. And you now are prepared to go to the next step, which of course is placing the stainless steel crown. So I do like the Viscostat product. It's one that is given by Ultradent, and what I like about it is that it comes with a syringe that has a female end that connects to the male end of the large container from which you order it, and you will notice that you only need a very, very small amount. In the syringe, which comes exactly like you see it, you then screw the applicator on, and it has the cotton tip here with a minimal amount of ferric sulfate. So I happen to like this, although there are many other ways that you can get it. In 1997, there were a couple of researchers who began to look at ferric sulfate versus formicreosol for pulpotomized molars, and they published in the August of 1997 Journal of Pediatric Dentistry, where they talked about the fact, and the emphasis is mine, they showed no statistically significant difference in the success rate of ferric sulfate versus formicreosol after 20.5 months. Then, in 2004, there was a follow-up where they had a longer follow-up, where they had an evidence-based assessment of evaluation of formicreosol versus ferric sulfate, and once again, they showed that they are likely to have similar clinical and radiographic success. So let's talk a little bit about the ferric sulfate technique. You follow all the same steps for the formicreosol, where you open up into the chamber, but the way that ferric sulfate works is it does not fix the pulp stump. What it does is it chemically binds with the heme in the blood to form a clot. So as a result of that, you don't want to leave any more of the ferric sulfate in the chamber than you must. So what you will do is you'll follow all the same steps that we've outlined for formocreosol, and then you will step the burr down by one size. So if, for example, you've been using a number 8 burr, you will step down to a number 6, and you put what I refer to as a countersink. You may call it whatever you want. Basically, you're simply going farther down the chamber. You'll recall with the formocreosol we stopped about here, and with the ferric sulfate we will drop down to here. What this does is it reduces the size of the exposed area, and once again, all of the bleeding must be totally controlled. Once you have done that, the difference is that as you are looking at this picture, you will see what the pulp chamber looks like with the larger round burr, which would be the larger oval shape here. But when you countersink it, you are farther down and you will have a much smaller area of exposure for the ferric sulfate. When you place the ferric sulfate in there, it will actually form a coagulum in there, and you want that to be minimal, because if you were to place ferric sulfate in an area this big with the number 8 round burr, probably in 12 to 18 months, as you look at the follow-up x-rays, you will start to see that the ferric sulfate itself is beginning to chemically internally resorb the root chambers, and that is not what you want. So here we have a clinical example of a tooth that has been cleaned, and once again you will be able to see here that there is no hemorrhaging coming from the tooth, which makes it a good formocreosol candidate. And on the other side of the screen you can see the placement of the ferric sulfate. I typically find that if I put the ferric sulfate onto the well-controlled bleeding stumps for approximately 10 seconds, 5 to 10 seconds, that is adequate to get fixation. So now, as you were looking at these pictures on the left side of the screen, very nice picture of the fixed area in there, no hemorrhaging, ready to fill, and we go straight back to the zinc oxide and eugenol in order that we can go right straight ahead to placing the crown. So you do fill it with the thick ZOE cement, and then you place the crown, and you have a tooth that has been well treated. I do want to mention that there are other pulpotomy techniques that are available. I think it's important that everybody know that the two that I've outlined are probably by far the most popular at this moment, but the other ones include electrosurge. Electrosurge technique is basically the same as what we've been talking about. All of the mechanical procedures are the same, but instead of using a medicament such as formocreosol or ferric sulfate, you would use the electrosurge unit to essentially electrocauterize as opposed to chemocauterize the pulp stumps. MTA, mineral trioxide aggregate, is gaining in popularity very quickly. I personally have never used it, so I cannot speak from experience, but I do know that studies are beginning to show that it is very, very successful. What I have come to understand is that it is expensive to purchase and that it is difficult to mix. But I'm not telling you these things to discourage you from using it. I'm simply saying that, that these are some of the situations that have come up in the past. The other thing about mineral trioxide aggregate is that it is basically cement, as in Portland cement, so that if you are packing it too far into the radicular portion of the pulp chamber of a primary tooth, and then you have a permanent tooth coming in behind it, it will disrupt the normal resorption of the root, because obviously concrete will not resorb as the permanent tooth is coming in. However, I would direct you to the literature for MTA. It is gaining in popularity. I have not gone to it only because of my great satisfaction with the ferric sulfate technique. I put calcium hydroxide on the screen only because of the fact that I want to say that calcium hydroxide has been shown to not be effective, although many people ask me about it. So as a rule, calcium hydroxide is really not that effective. Now, before we move on to the pulpectomy, I would like to do a very fast poll here and ask all of you to log in with what do you normally use. Which pulpotomy medicament are you currently using? We have formocreosol, ferric sulfate. I want to see how many of you are using MTA and how many of you are using other, something else. So this is only for my curiosity. Nobody's grade is going to be based on this. And I'll give you about another, 10 or 15 seconds to log in real quickly. I do not know who is casting the votes, so it's not about who's right and who's wrong. I'm simply curious to know who is using what. So let me give you about 5 more seconds here, and then I will show you the results. So I'm going to close the poll in about 5 seconds. I'm closing the poll here. Let's take a look at what the results came in. So interestingly, you will see that almost 70% of you are using pharmacreosol. About 18% of you are using ferric sulfate. Almost 5% of you are playing with MTA, and 9% of you are using something else. There are many medicaments that are probably effective. I would only caution those of you in the other category that if you are using calcium hydroxide, I would caution you to watch your follow-up x-rays very carefully. Let's move on to pulpectomy. Now, I've discussed with you the fact that pulpectomy is a procedure that you will do on a tooth that is non-vital. And the key here is using an agent which I have found, I've actually been using this for many, many years, called Vitapex. It is made by the Neo Dental Company in Tokyo, but is available from your local products man. I purchased mine from my local dealer here in Olympia, the local dental rep. And you will see on the screen that, that really Vitapex is nothing more than calcium hydroxide and iodoform paste. So, so you can see right here, iodoform and calcium hydroxide paste. Now the calcium hydroxide becomes very effective for pulpectomy, but not so much for pulpotomy, and the iodoform is what will help with the healing as you proceed. In 1999, these researchers were the first ones that really came out with an article that talked about Vitapex. And you will notice, again, the emphasis is mine, that in one session treatment with Vitapex resulted in no clinical failures over 3 to 22-month follow-up. Advantages included resorption from apical areas in 7 to 60 days, radiopacity, and no apparent harm to the permanent tooth buds. You're probably thinking, this is too good to be true, and I'm going to tell you, it is true. So this is the tooth that I told you about. It is a first primary molar, which I would normally not have done, but this happened to be a daughter of a friend of mine who is a dentist. You will see in the x-ray that the 6-year molar is not yet erupted. Under normal circumstances, I probably would have extracted this tooth, but he said, please, would you just try this out? So I said, good enough. So this is the technique. When you open into the chamber, you will see there is no sign of vitality. That's very clear on the left-hand side. On the right-hand side of the screen, you will use just normal files. You don't have to measure them. You basically eyeball it, which I know for any of you who do endo must seem terrible. But in primary teeth, there are so many accessory canals that you really cannot totally clean the chamber in the fashion that you would clean a permanent tooth. It is a function of how the primary teeth chambers are shaped. Once you have them clean, you will then rinse them with a peroxide rinse and use paper points to dry them. Then with the Vitapex, which comes in a beautiful container, a beautiful syringe with a very, very fine tip, you can put that tip far into the pulp chamber and begin expressing the Vitapex into the chamber, watching carefully, because the one drawback of the Vitapex is that it will tend to stick to the syringe. So the moment that you see the yellow material touching the syringe, you will begin simultaneously injecting the paste and withdrawing the syringe, so that you will be left with the pulp chambers as obliterated as possible, as you are now seeing on the right side of the screen. Then you will mix a thick ZOE paste so that you can place it into the chamber, and with a plastic instrument or with a condenser or with a burnisher or whatever you like, you begin to condense the ZOE so that you will hydraulically push the Vitapex farther into the chamber. When you take your first post-operative x-ray, you will be horrified, thinking, oh my goodness, I have overfilled this thing. However, as the Nurko and Garcia Godoy article indicated, the material will resorb, and as you can now see, in 1 week you already see substantial resorption, and by 1 month it will begin to look perfect. And as you see the area of bone around the tooth, you will also see that it will begin to fill in quite nicely. Now, the other thing that will probably be slightly amusing but also slightly scary to you is that if you get really enthusiastic with condensing, you can often drive that material all the way out through the perulus. But again, I do not want you to worry about that, because 1 week later, same tooth, same child, you will see that it is completely cleaned out. Let's go back to the indications again, just so that everything is really clear to you. As we are looking at this tooth, there are a number of factors that make this tooth a perfect candidate for a pulpectomy. Here they are. Working from left to right, we have an unerupted 6-year molar, which, as I've described, we want to keep this second molar to guide this one into the proper location. We have good anatomy of the chambers. We don't see any internal resorption, and that is good. We are seeing that we already have some interradicular problems here because of the direct communication of the caries into the nerve, so we have a non-vital tooth. And last of all, we have a missing first primary tooth. So we cannot put a crown over here and bring a distal shoe back. We want to try to save this tooth. This is the classic picture of a tooth that is a perfect pulpectomy candidate. Here is that tooth completed. You're looking at a 3-rooted tooth, and you now know that when we have that excess that is pushed down into the bone, we are not going to worry about it because it will resorb. I am sorry that I do not have a follow-up picture on this particular child. However, I will show you one in a moment of what cases of this sort look like. Here are some poor indications for a pulpectomy. Now, first of all, the tooth that you're looking at on the right side of the screen already has internal changes in the chambers, which already makes it a bad candidate. But as I have said before, it's a bad candidate also because it is a first primary molar tooth anyway. So under a circumstance like this, what I would recommend doing is extract this tooth, and I would put a band on this tooth and a loop and bring it up to the cuspid so you have an extraction and a band and loop. This is not going to be a tooth that will be successful for a pulpectomy. Here's another poor indication. In spite of everything that we wish we could do for second primary molars, sometimes we cannot save the tooth even under any circumstance. In a case like this, the arrow is now indicating how we're seeing that we have some apical resorption on that mesial root. And the other thing that I want to point out to you here is the fact that we have really a very, very large area of bone loss that's interradicular, and also the entire area that is below that mesial chamber. In a case of this sort, I would say to you, there is not going to be a way to save that tooth. So finally, I want to show you a picture of a finished case. This is really sort of the nice summary of the whole presentation, in that we have a second primary molar, which you will see very clearly has been crowned and has the 3 chambers. The vitapex has come right to the tip of the chambers, and any excess that might have been there has resorbed away. It's the classic example where we have an unerupted 6-year molar. And over here we have a crown that sits on a tooth that has had a ferric sulfate pulpotomy, and you will see how the material that goes down dives a little bit farther down into the chamber because of the fact that we had to use that countersink that I have explained to you. Now, before we finish up, I want to run one more poll here, just for my own curiosity, and that is I would like to find out from all of you, how many pulpotomies are you currently performing annually in your practice? Are you doing like 10 or fewer, 11 to 25, 26 to 50, more than 50? I'm just curious who my audience is. So once again, we really want to make sure that I don't know who's voting. I only know that people are voting. I'd like to give this about 10 more seconds, 15 more seconds, and then I want to get to your questions because some people have asked questions that I would like to be able to answer. So once again, how many pulpotomies do you perform on an annual basis? Let's give this about 5 more seconds, and then I'm going to close the poll. Okay, let's close the poll and see what we have here. Well, it looks like about half of you are doing a few. And boy, some of you, 20% of you are doing more than 50 a year. That's quite a few. That's more than 1 a week. And so I applaud you, and I hope that the material that we have discussed today will be helpful to you in terms of how you are proceeding. Okay, so let's get to a few of the questions. The question is, can Vitapex be used in treating permanent teeth? You know, I don't feel like I can answer that question fairly. I do believe it can be used, But because of the fact that I personally, as a pediatric dentist, do not actually do endodontics on permanent teeth, I cannot give you the definitive answer. However, conceptually, it certainly is a material that could be used well, and my best guess would be that, that probably the answer is yes, you definitely can use Vitapex in permanent teeth. Another question. Is it possible to use ZOE as a filling material for pulpectomy? Yes, it is. However, when you use ZOE as a filling material for pulpectomy, you will want to make a very runny mix of ZOE so that it's very liquidy, not liquidy, but very runny, more like a fluid. And then you will put it onto a reamer or a file, and you will reverse spin the file so that now, instead of it's corkscrewing up toward the crown of the tooth, it will be corkscrewing down toward the apex of the tooth, and as you do that, it will actually spin the ZOE down to the base of the chamber, and once you have done that, you then return to the same technique of putting a nice thick ZOE paste on there in order to further condense it down the chamber. So yes, ZOE can certainly be used for pulpectomies, and it works out quite nicely. Let's see. Okay, if the first primary molar tooth is abscessed and the child is 4 years of age, what is the treatment for that? If a first primary molar tooth is abscessed, I will always extract it and put in a abandoned loop. It is a better choice in my opinion because pulpectomies don't really serve, in my opinion, as well on first primary molars because of that anatomical difference. Another question, could you please tell us something about electrosurgery for pulpotomy versus formocreosol in case we need to do it during electrosurgery? Basically, as I've said, the technique will be exactly the same where you go in and open into the chamber, you will amputate the coronal portion of the pulp in order that you have no hemorrhaging, no bleeding, and when you have those two little red snake eyes that are not hemorrhagic, which again is indicative of a tooth that is probably hyperemic and needing a pulpectomy, if you have those two little red snake eyes, you will then take your electrosurge unit and just briefly touch the tip onto each of the pulp stumps, and you should be able to see them immediately cauterize. From there, the technique will be exactly the same as you do for anything else. You will then treat it with your ZOE and proceed with the crowning. Okay, let's see. The question is, with those back-to-back very large interproximal lesions with significant space loss, what is your technique for customizing stainless steel crowns? Okay, since this is not a pulp question, I'll answer it briefly. That when you have back-to-back crowns, I use the straight-walled crowns, and I actually did a 3M SB seminar on webinar on crowning, which you can pull up and see. But when you have those back-to-back crowns, I will always fit the second primary molar crown to the best of my ability and get the most ideal fit on that one. And if I need to compromise, I will compromise on the first primary molar crown. Occasionally, because I use the straight-walled crowns and use a contouring plier to get the curvature, one of the tricks when you have a lot of interproximal space loss is to take those contouring pliers, and rather than putting the boot, as I call it, into the inside of the crown to get the positive curvature, I put the boot on the outside of the crown to dimple the crown, and in that fashion it's possible to actually get them to fit better. Okay, the role of formocreosol in fixation of the tissue is to stop the bleeding. No, that's a very good question. The question is, what is the role of formocreosol fixation of the tissue? It is not to stop the bleeding. It's critical that when you use formocreosol that you already have the tissue that has stopped bleeding. If the bleeding is continuous, you probably have a hyperemic pulp, and it will not be successful by just going in with the formocreosol. The formocreosol can go in there, but if you still have bleeding, it's probably indicative of a tooth that you shouldn't be doing a pulpotomy. The question is it safe to say all necrotic primary teeth should be removed and space maintained with an appliance for the sake of saving permanent teeth? No, I would say that if it is a necrotic primary tooth and there's a second primary molar, I would proceed with a pulpectomy, which is what you are looking at on the screen as we speak. The first primary molar on the screen is a pulpotomy. If it had been necrotic, I would have extracted that tooth, but not the second primary molar. Pulpectomies on any primary tooth do not have a 100% success rate. However, If, as with the situation you're looking at the screen, if you can save that second primary molar even for another year or 2 years, you can actually hold the 6-year molar back, and if the tooth eventually, if the pulpectomy fails, you can still extract the tooth, but then you have the 6-year molar in the proper spot in order that you can then put a lingual arch on. Okay, the question is, if ferric sulfate can cause internal resorption, then why should we prefer it over formicreosol? I'm not saying that you should prefer it over formicreosol. I'm saying that formicreosol has some issues, and if you do the countersink technique, you will find that any internal resorption will be radically reduced. I have been using that ferric sulfate with the countersink for about 10 years, and I would say that my failure rate now is maybe 1 or 2%. I like it because it's faster. I like it because it doesn't smell. I like it because of the fact that it's just way easier to manage the pulp very quickly. So I particularly happen to like it way better. The question is, can ZOE and gutta percha be used in root filling? Not in primary teeth. You cannot put an object into a primary tooth, such as gutta percha, because gutta percha will not resorb as the permanent tooth is coming in. So, so really, you must always fill primary teeth with some kind of resorbable medicament, which would include the Vitapex and also includes ZOE. Now, sometimes I will tell you that with the ZOE, even the runny ZOE that I have described, you will find that it will form a totally solid mass that does not resorb all that well, which is one of the reasons why I really like the Vitapex way better than I like the ZOE technique. Okay, I think that we probably need to wrap the presentation up. I really appreciate your questions. I'm sorry that I didn't get to all of them. I got to as many as I could. What I would like to suggest is you are now looking at my name. You are looking at my website, which is saltus.info. There is no com, edu, org. You are looking at the entire website, saltus.info. My email address is drsaltus@orcalink.com. If you have any further questions, please write me a note. I'm very good about responding. I'm not good about responding fast because there are more of you than there are of me. But if you have further questions, please feel free to write. And I also want to acknowledge that a couple of people in the question category said, great lecture, and I really appreciate very much your attending the program, and I hope that it has helped you to understand pulpotomy better. So we are ending the program, and I look forward to hearing from you again.